Hi. Good morning, everybody. I'm Abhi. I'm one of the PGY-5. I'm currently the spine chief at MSH, and this is a spine conference where we'll continue the theme of vascular that has been going on during this grand rounds, and also learn some spine along with it. All right, so we'll first start with a case. We'll start with Dan. Can you go through this case?
Sure thing. Thanks, Hobby. So a female in her 60s with several month history of constipation, groin and proximal leg numbness, and gait imbalance. Presents outside hospital with acute worsening of bilateral extremity weakness, giving out decreased sensation and urinary retention. Yeah, so it sounds like, she has subjective weakness, and then the obviously the post-void residual is concerning for something going on in the spine. So certainly would want like a precise motor exam and see objectively what her exam is at this point.
Correct. Awesome. So she's at an outside hospital, and you'll see this a lot once you come to the MSH next year. You're calling the outside hospital, you're asking them for a motor exam, and they will just tell you that patient is just diffusely weak in lower extremities, not really able to ambulate, unable to bear weight, but has some resistance. That's the neurological exam you will get over the phone. So what would be your next step?
Yeah.
What are you thinking?
Right. So it sounds like she's acutely weak. So she's had several months of numbness, but how acute is the weakness? Like, is this something we need to potentially take to the operating room acutely? Like, is this in the past hours, days, weeks? So.
Correct. So this has been going on for the outside hospital. They said it's been going on for the past year or so, and they will show us. They ended up getting a CT of the lumbar spine with you, and we can move on to Ansley. Are you able to tell us what the significant findings in the CT are?
Yeah, so I'm looking at a sagittal view of the lumbar and sacral and part of the thoracic spine here, and I'm counting up. I think that let's see, 5, 4, 3, 2, 1. It looks like there's maybe a vertebral body compression, sort of wedge fracture at T12. And then also lower too, it looks like there's maybe some diffuse osteopenic. So that's maybe 5, 4, 3, 2, L2 as well.
Okay. Awesome. You're correct. So there is an abnormality here at T12, and there is looks like some stenosis here at 4 or 5. Say the outside hospital shows you the scan, and they're saying, "Doc, we see an abnormality here. You think this is causing the patient's symptoms?" Do you know what this might be suggesting?
I'm sorry to interrupt. I have a question. Maybe I didn't hear it, but was there any finding on neurological exam that would distinguish between an upper motor neuron level and a lower motor neuron level, like reflexes and Babinski sign? Because a thoracic level compression can also give you urinary retention and weakness in the legs.
Right. Yeah, that was going to be my point, because the consult from an outside. So we ended up passing the patient over, and the next slide has our examination, including the reflexes. We'll go through it in a second. So this is a Schmoll's nodule. It's an asymptomatic finding that can be presented up to 70% of the patients with no clinical significance on this patient. So like Dr. Hooten mentioned, the patient's symptoms can be localized above the lumbar spine. And given that we don't have an outside hospital examination that is satisfactory, what would be our next step given that we are concerned for a neurological pathology? Emily.
So I would I'd like to see an MRI for this patient, do thoracolumbar, just to take a better look at the canal and given this acute weakness and urinary retention.
Okay, good. So say they're saying this is, they can get an MRI within 24 hours. What would be your response? They just don't have the capacity.
Yeah, that's not an acceptable time frame for this sort of presentation. Like Dan mentioned, this might be taken acutely to the OR, and so if they don't have the MRI capacity at the outside hospital, then we'd have to bring the patient over to get that imaging here.
Exactly. Yeah. So whenever we have not a concern for an acute neurological finding and not a satisfactory exam, we should, it's reasonable to transfer the patient ED to ED to have the patient be evaluated by our own team. And as Dr. Hooten mentioned, doing their own neurological exam is important because the lesion could be localized to above the lumbar spine, given the extent of the weakness and other presence of any other upper motor neuron deficits. So the patient's exam, you can see patients diffusely weak in the bilateral lower extremities all the way up to proximal and diffuse loss of sensation, including around the perianal region. But the patient does not have a Hoffman clonus or hyperreflexia, and patient does not have any bowel incontinence, and patient does have a present rectal tone.
What about the Bhimani sign?
Bhimani sign was negative per her note.
By the way, it's a picky point, but when you describe the Bhimani, you should say it whether it's present or absent. Technically speaking, there's no such thing as a negative Bhimani.
Yeah, correct. So Bhimani sign was not present. So we have an MRI spinal survey on arrival, as we discussed. Let's go back to Dan. Is there any specific abnormality you see on this MRI?
Yeah, so we're looking at a T2 sagittal of the lumbar and thoracic, actually going all the way up to cervical. Just trying to move my computer so I can see the whole thoracic, but I definitely see an epidural. There's something, some epidural substance going on at 5, 4, 3, 2, 1 for L1 down to at least L1 to L2 most, prominently. So there's some compression at the level of the conus, that could be causing this acute weakness, basically. Either abscess.
And what are your thoughts on the? What are your thoughts on the thickness of the conus? Is it normal? Is it abnormal compared to higher spinal levels?
Yeah, it definitely looks thickened. Yeah, the conus looks kind of thickened compared to the more cranial portion of the cord.
Correct. Yeah. So we don't see any specific large disc herniation, but we do see some, like basically a congestion and thickening of the conus. And I'm not sure if this is evident here. Do you see these dots behind the here?
Yeah, I do.
We'll go to Ashley. What do you think these might suggest?
I think the dots in the white. I'm not too sure. Maybe some type of a growth. Maybe
Well,
type
yeah,
of
we have congestion, right? Huh? Cerebral venous. What do you think?
yeah, if it's like a venous thing, so maybe like a dural AV fistula.
Yeah. So yeah, this suggests there's some enlargement of the veins. So you are correct. So the MRI spinal survey shows a congestion and a long segment edema of the spinal cord, and edema is most significant as the conus, as you mentioned. Any further imaging based on the current concern that Ansley and Dan mentioned?
Yeah, I think if we're concerned about things like AV fistula, I think obviously a DSA would be like the best way to confirm that. I think ahead of that, we could also try getting in like an MRA as well, or a CTA.
Excellent. Excellent. Awesome. Awesome. So we ended up getting an MRA on this patient. And, it's can be sometimes hard to interpret. So we have labeled it here. There's a dilated vein here, and there is a fistula here where the arrow is. So there is a concern for spinal dural AV fistula. And like she mentioned, furthermore, patient underwent a diagnostic angiogram that showed a dural AV fistula at T11. And as Ansley mentioned, the engorgement, you can really see the venous engorgement due to the fistula and the connection here, or arterial venous connection, causing the edema and the acute weakness, acute progressive weakness of the patient. Emily, so this is a spinal angiogram. Can you identify this structure? This is a classic structure you'll show in boards and given a spinal angiogram. You don't have to worry about the levels because it's hard to see levels from this. But what do you think this is?
As I'm noting that hairpin turn, I think that's the artery of Adamkowitz.
Great, awesome. So yeah, every time there's a arterial fistula, we also want to see where the artery of Adamkowitz comes out. In this case, it was at the T12 level, a level below our AV fistula on the left side. All right, and how would that affect your decision making? Go to Noah. How would the location of the Adamkowitz affect your clinical decision making in treating the dural AV fistula?
So the artery of Adamkowitz, it provides basically a large territory of the spinal cord. So we absolutely have to know that before we intervene operatively. But basically that we just need to know that because in order to treat this lesion, we are going to have to apply vascular clips in order to occlude both the arterial and venous portion of this lesion. So that's basically how it's going to factor into our management.
Correct. All right, and we'll discuss more when we discuss treatment option. So spinal dural AV fistula is the most common vascular malformation of the spinal cord, and it has initial classification criteria that we can review here, with type 1 being in the dural AV fistula and the dorsal sleeve nerve root, and all the way going into type 4, which is an intradural perimedullary AV fistula. And subsequently mentioning the feeders for each type. There's a Spitzer classification as well that kind of builds up on it. And this is classified as a dorsal intradural AV fistula. And they're generally located in the thoracolumbar region, and there's a very high male prominence epidemiologically. Pathophysiology. As we discussed earlier, there's a direct connection between the meningeal arterial branch as well as venous coronary process of the spinal cord, causing significant congestion. This is a figure from the Neurosurgical Atlas that really shows, the pathology very clearly, as well as the congestion that can be caused and patient can become clinically symptomatic with progressive weakness from this edema of the spinal cord. And you can see the spinal radicular artery as well here, as well as the perimedullary vein. All right, let's go. All right, so we can discuss radiographical diagnosis and localization. So as Chi mentioned earlier, diagnostic angiogram digital subtraction angiography is currently the gold standard for the diagnosis and localization for biliary fistula. However, there are some studies that were dabbling into the efficacy of MRA alone as a tool for diagnosis and localization, and this could be beneficial in a lot of the centers that do not have timely or routine access to an angiogram. There's a meta-analysis that found a 98% sensitivity and 79% specificity of MRA in terms of localizing or in terms of diagnosing biliary fistula. However, there's probably a decent amount of publication bias given that it only included 2 studies, and there isn't really a lot of data supporting MRA alone for diagnostic and localization, given that only 59% of the cases, and this is probably the best case scenario, predicted the correct level. And if we're doing operative planning and we would like to do a laminectomy, having the correct level of the biliary fistula would make the surgery significantly less invasive and safer. So I don't think we are at a point where MRA could potentially replace the diagnostic angiogram as a gold standard. All right, sorry, one slide ahead. Ansley, what are the treatment options?
You can do an endovascular approach to embolize. You could do open surgery, and I think you can also do, can you do radiosurgery as well?
I agree with the endovascular and surgery. Radiosurgery is there. I couldn't really find much literature on, especially biliary fistula as a single feeder, radiosurgery on it. So I think the current tool is mostly surgery versus endovascular. And the main goal of the surgery would be the ligation of the draining vein. A little bit about the surgical management of the AV fistula. The first documented surgery was in 1916, so over 100 years ago. Surgery includes a laminectomy, dural opening, and the focus is on the ligation of that draining vein. And since 86% of the dural fistulas are fed by a single feeder, it provides a relatively easy access to the draining vein and makes surgery relatively quick, given that you have precise localization of the dural fistula. And as we'll discuss next, surgery can also be done minimally invasively with a lot of recent publications showing that and very good outcomes with much less invasive surgeries. This is a picture from that same patient that was taken to the OR by Dr. Jones. And as you can see, this is the dilated vein. And this is the connection. We have the dura open, and you can see the connection to the vein, to the arterial connection here, causing the congestion, which is cauterized. And, eventually micro scissors is cut, and that is your surgery. Obviously, after that, you have to ensure a watertight dural closure. And the patient ended up doing really well and ended up being ambulatory with 4+ out of 5 strength and was discharged a few days after the surgery. It just shows you how significantly these patients can improve and the importance of recognizing this kind of pathologies, especially when we are called from an outside hospital where they may not have people trained in doing a proper neurological exam. So you kind of have to take, what are the best exam they can get with your medical judgment. And when in any doubt or concern, very low threshold to transfer the patient and evaluate ourselves so that we don't miss any kind of an acute pathology. So she ended up doing really well. And there's, as we discussed earlier, there's minimally invasive surgical options, especially with tubular retractors, using Metrix tube. There's a lot of videos. There's a video on neurosurgery and on GNS showing, very good outcomes for like very small laminectomy, as long as the dura is open relatively safely through the Metrix tube. It shortened the recovery time of the patient, and some surgeons have also been using intraoperative ICG to preoperatively see the dural fistula, and after cauterization, the lack of flow in that. In that case, you can even avoid sometimes a postoperative angiogram. If the ICG shows resolving connection between the arteriovenous abnormalities, although it has not been widely adopted yet. And angiogram still remains the gold standard postoperatively to check for any residual. Moving on to endovascular. So endovascular management of dural fistula, especially ones with single feeders, it was first recorded as a percutaneous embolization in 1968. There was this, scan paper. However, it has obviously become increasingly more prominent as a first-line treatment due to its less invasiveness, and embolization can be performed during the initial diagnostic angiogram, which most patients are going to get to be able to confirm the location and diagnose dural fistula. So, on to Emily. What do you think would be the pros and cons for surgery versus embolization for dural fistula? Just knowing their general risks.
I mean, there's always the general risks of anesthesia time and depending on the patient's other comorbidities, how they're able to tolerate. Obviously, longer anesthesia time for open surgery. I think also, like we were talking about earlier, based on the relative location of the artery of Adamkowitz and how likely we could there's a risk of spinal cord stroke depending on the proximity of that artery. I think I would, in that case, if there's a high risk for stroke, I'd probably favor endovascular in that case, due to faster access to all the vasculature, all the local vasculature. Yeah, so those are some of the general specific risks I can think of.
Okay. Yeah. So so there's obviously risk of invasiveness, as you mentioned. However, now we'll discuss more regarding the Adamkowitz, because it actually makes endovascular a much more challenging treatment than surgery, because you have to think about it that when you treat something endovascularly, you're going through the arterial, you're going through the artery, right? So you're going through those arteries and embolizing that connection. The surgical approach, you're exposing the venous side of the things, and you're just ligating that vein. So you are not getting into Adamkowitz because you are intradural. You are basically targeting that venous connection inside. So you have zero risk of getting the Adamkowitz with surgery, as long as you localize dural fistula. But as you discussed, surgery is technically more invasive, and there is a risk of CSF leak and an infection. However, now over 98% or even higher patients have complete radiographic occlusion of dural fistula, and they do not have, most of them do not have any long-term recurrence. There was 2% complication rates shown in a lot of studies with no mortalities, and 80% of the patients have a significant improvement in the neurological symptoms. Endovascular, it is less invasive, and there is obviously avoid things like a CSF leak. However, the success rate has been wildly varying between 40 and 90%. And as we discussed, if Adamkowitz arises from the same segmental artery, as your durating fistula, then it is relatively contraindicated to try embolization because you do not want embolization material going into the damquits because you're coming from the arterial side from the outside. In the surgery, you're going from the inside and ligating it. But it is a relative contraindication, not absolute. And it's important to note that the success rate of endovascular embolization has been improving, as the experience of the proceduralist increases and as endovascular becomes more and more common. A lot of the endovascular patients also may require multiple embolization treatments to achieve a complete occlusion, whereas most surgical patients, especially with single feeders, would not need to return to the operating room, provided they do have localized AV fistula correctly with angiogram. And this is a theoretical risk, but an angiogram may miss smaller feeding vessels to the anterior spinal artery. So, there could be feeding vessels going into the anterior spinal artery that the angiogram may miss, and there could be a theoretical risk of causing an infarct. So that is also something we need to keep in mind. I couldn't find a lot of literature. There have been individual cases, but there is not a prevalent literature on the rate of any kind of a spinal cord infarct after an embolization of dural AV fistula. It is a rare occurrence because the patients are screened out if they do note any abnormalities on a gross angiogram. But sometimes, not all the centers have, like Dr. Shigematsu was mentioning, it is just as important to do a high quality angiogram instead of just angiogram. And if, the angiogram is not done correctly, then you may miss those small feeders that accidentally embolize something important, especially the anterior spinal artery branches.
Can I just comment there, Abhi? Thanks for
absolutely.
So, endovascular is very straightforward, and so is surgery in these cases. When you're doing the endovascular angiogram, you identify the vessels that supply Ademkowitz. Often it's one, sometimes it'll be two, but almost always it's one. And you make sure you can see all the levels above and below the fistula on both sides. So you have a good idea about what the anatomy is, and you only embolize if Ademkowitz is not on that radicular artery. But if it's not on that radicular artery, then it is safe to embolize, and that can be done effectively. But you've got two very good treatments here, and so identifying the one that is the lowest risk is the goal.
Absolutely. Yep. And to echo what Dr. Kellner said, so far, the high quality digital substructure angiography is absolutely essential and plays a crucial role in localizing the AV fistula, regardless if you decide to go for embolization route or the surgery route. Patients should get a diagnostic angiogram to really treat the patient safely. And right at this time, the surgery has there's a slightly higher success rate for surgery compared to the endovascular treatment. But as we said, it's been getting better and better, and it varies with the center and the experience of the proceduralist. It remains a mainstay treatment for now, but endovascular is also appropriate, given the center and the proceduralist has experience for that pathology.
Yeah,
happy to answer any questions.
Couple of comments on this. Great job, Abhi. This was an interesting case in that there was sort of a rapid deterioration that the patient had, which is a little bit atypical for the normal sort of slow progressive indolent kind of presentation that you usually see in like older men, a typical patient. I think, as Dr. Kellner said, we have both pretty good, pretty straightforward treatment options in endovascular and open, and there are certainly some contraindications, right, to endovascular when you have a ISO level spinal artery. But I think the big picture here is the rapid diagnosis, recognition, and treatment for a couple of reasons. Number one, this is unusual in a good way in that we caught and identified this lesion and treated it very quickly, and the patient recovered very quickly. You know, historically, the longer the patients wait, the more chronic the edema is. Often the recovery is not as good, even if with a successful ligation. The other thing is that, you know, this was a fairly obvious fistula on the MRI. So we knew we were going to find something. We just had to find it. But the key is really I was always taught you win the game when you localize it, right? Because then you have two very good treatment options. But localizing it is really the key. It's not always this straightforward. And I think that historically patients undergo something like 1.8 spinal angiograms before it's actually found, right? So really good spinal angiography, I think, is really important. It's not always obvious from the non-invasive imaging if there's a shunt and where there's a shunt. So when you have a less obvious case, you have to be very diligent. And often, if you don't find it, you know, repeat the spinal angiogram with a high index of suspicion, because it's not always this straightforward to find a lesion. And we know that if you wait longer before finding it, then the outcomes aren't as good. So, you know, in this case, we were able to find it very succinctly and quickly. But if you don't find it, you really have to do a stem to stern spinal angiogram, good quality, and make sure you're leaving no stone unturned, because you don't want to give a false sense of a false negative, right, from a negative but not adequate spinal angiogram, because that's the scenario that's worse for the patient, right? And I think with the MRA, you know, a time-resolved MR spinal angiography is I think helpful, useful. It's gotten better. In my experience, it's not often as good quality as the one that we had for this particular patient. And I view it more as a screening tool, but not something you can really hang your hat on diagnostically. Either way, a negative result or a positive result, you really still need spinal angiography.
Thank you, Abhi, for preparing this talk. I agree with everything Dr. Caton said. We discussed this. I was quite impressed with the MR angio, and I've not seen one of this quality. But again, you really want to be certain about the levels, and also whether the fistula is on the left or the right side. And you know, we were able to move quite rapidly with this patient, with the ER, with the radiology. And I just want to give thanks to Gustavo, who was on the team that night, very responsive, directly communicated everything for the patient. And also, you know, our MRI tech, we were able to review the imaging in real time and add the necessary protocols right there in the MRI scanner to help establish the diagnosis. And of course, Dr. Caton was more than willing and capable to help with solidifying the localization. One thing I want to add, the MR angio, it seems like it is improving. I think that's an exciting area. But again, these fistula, there's a spectrum. You know, they might not always be obvious. So I just want to echo what Dr. Caton. I think there's always going to be a role for a catheter angiogram.
Abhi, can you hear me?
Yes, sir.
Yes. So first of all, excellent presentation, interesting case, intersection of spine and vascular, the theme of the day. I will say that a couple teaching points on the presentation. Number one is, I think Emily mentioned early on doing thoracolumbar MRI. And I think that if someone comes in with leg weakness and with has bowel and bladder dysfunction, I think you have to do a full spine survey, and that was what was done. And was I would say that the other teaching point is the index of suspicion needs to be high. And right now, I would say that we've had a lot of cases with delayed diagnosis. MRIs often don't find it, as you pointed out, and I think surgical versus endovascular remains mainstays. Thank you.
Awesome. I think
Thanks
that
a lot,
should
Abhi.
be it for
Is
our
there
talk
is there more
today.
there?
Oh, no, I think that should be it for our talk today.
Okay, great. All right. Thanks everybody for a great discussion.
Thank you, everybody.
Great day.